we're going to talk about chest pain because there's been a lot of updates in the chest pain landscape, including how we talk about it and also how we find ACS on the EKG. Now, back in 2021, there was a multi-society chest pain guideline update that discouraged the use of the term atypical chest pain, which we used to use all the time when it didn't seem cardiac. But now what they want us to do is to use terms like cardiac, if we think it is, and possible cardiac, if we suspect it, and non-cardiac to describe the suspected cause of chest pain. So that's a big paradigm shift in the way we look at this and describe it. So know that that's been going on for the past 3 years, that paradigm shift, and you're going to start seeing documentation reflect that. Now, that happened because they found that too many atypical chest pain patients were being not properly worked up, and there was some missed ACS. Now, the other thing that I am so passionate about is this new consensus document that they put out in November 2022 in the Journal of American College of Cardiology. It was called the Chest Pain Guideline Update on How to Manage Chest Pain in the ER. Now, what they did was they basically said that there are some new STEMI equivalents, in fact, 5 of them, that weren't really on the radar before. And there's a couple of them I want to highlight. Now, the first one is posterior STEMI. This is where you're going to see some depression of the ST segment in V1 through V3, assuming that there's some reciprocal depression in the posterior leads. And you can confirm this with doing a quick repeat 12 lead, getting V7, V8, and V9. And you only need 0.5 millimeters of ST elevation to confirm it. But the thing in my mind is like, why is this a STEMI equivalent? This is actually a STEMI, right? So that one's easy. And then the other 2 that they threw in are basically Scarboza's criteria. And this is something that I know has put fear in a lot of students and a lot of current practitioners because it's very complicated. And basically what it's used for is how to find STEMI in the setting of a left bundle or a paced rhythm, because it can be pretty difficult. So there's some criteria to follow. So they threw that in. And then the other 2 that are now STEMI equivalents are De Winter's sign or De Winter's T waves, and then hyperacute T waves. Now, De Winter's are basically just really big, prominent symmetric T waves associated with some ST depression, usually in V3 and V4. About 2% of LAD occlusions will present this way. It's pretty rare, but it is very significant and does now meet the criteria of being a STEMI equivalent. And lastly, there's hyperacute T waves, and those are, we used to think, those were seen in like pre-STEMI. And now because they know that they progressed to STEMI, they were like, let's just throw it in so that we catch damage early to the muscle and do something about it. So what they are broad symmetric T waves that are seen in contiguous leads, and they're T waves that are almost as big as the QRS, but they're not hyperkalemic T waves, which are the ones that are very sharp and peaked. So that's the difference. So if you want to learn more about this and maybe see a couple of these, we're going to be doing a presentation Tuesday of next week. You can join us. It's completely free. It's a high-risk EKG masterclass with the new STEMI equivalents in there. I also talk about the other things they added in this article on the bottom of a table that they list. I'll be showing you that table where they say people should go to the cath lab urgently. They're not STEMIs, but urgent. And one of those things is Wellens warning. So if you don't know what that looks like, or you need practice on finding ST segment elevation with elevation in AVR, that's now on there too. We'll be showing examples of that. So just go ahead and email me. I'll get you the link. We're going to be meeting Tuesday at 4 o'clock PST on Zoom, and I will see you next time.